but epicutaneous testing is the preferred method for people with allergic asthma, allergic rhinitis. But probably allergy tests are one of those tests that's performed way more often than it's ever acted upon. And so I think we only organise allergy tests, in my opinion, if you're going to do three things. One is if avoidance therapy is truly an option. And John touched on this before, like if you're allergic to a cat or a horse, and there's the real option of taking that allergen out of your environment, then sure, you could test for it.
Although patients have often self-identified that, haven't they?
Yeah, to some degree, but they reconfirmation of it, and it's hard to lose a cat or a dog from an environment if that's the case. The other options then is if you truly have a patient who needs to consider immunotherapy. So you're doing it to identify an allergen for the purposes of ongoing treatment, some sort of disease-modifying process like immunotherapy. The last one of all, and this is a really careful one, is when you need to confirm the diagnosis. In someone who's really got classic allergy, you don't need to confirm the diagnosis just to start treatment. But I think if you have a patient who's been on corticosteroids for 2 weeks and says, look, really, I'm no better, 5% better, then you have to stop and say, look, is this really an allergy that's occurring? And rather than have your patient stay on intranasal corticosteroids for months and months and months, maybe that's the time to say, is this an allergic rhinitis? Because a quarter of all rhinitic conditions are not allergy. And so there's quite a high proportion of patients who don't have simply an inflammatory or allergic condition going on in their nose.
And is it true that if you have a positive skin test that there's only about 50% real life match up, that people will react to egg where they eat egg with no problem?
Well, you should never do food. So there's very real relationship between food allergy and respiratory disorders. That's not to say that some foods can drive respiratory symptoms, but not in terms of typical inhalant allergy. So IgE-mediated allergy does not come from eating foods. It's really just inhalant allergens that should be tested. And you're absolutely right. What you get on the skin is evidence of prior sensitization. So there's a very strong negative predictive value with it. So if you really have no allergic sensitization on an epicutaneous skin test, then it's highly likely that what's going in your lungs and nose might not be allergy. But you're right in saying that once you get positive results back, you have to actually marry them up, because it's not necessarily what's driving the condition now. So if someone grew up with a cat or a dog in their house and they've developed Ig antibodies and that memory to it, they will come up positive as an adult. But that they may still be dust mite allergic or grass allergic, and you have to listen to their symptoms. Do they have seasonal symptoms? What triggers it clinically? This is why you never treat an allergy test. You have to use it in conjunction with their clinical story. Actually, a lot of the evidence suggests that allergen reduction or prevention methods in your environment are not very effective, because you can reduce, as you suggest, and spend a lot of money tearing up carpet, putting special mattress protectors, reduce your allergen exposure from 1 million parts per litre to 10,000. But if it only takes you 1,000 to trigger you off, you've really made no clinical difference.
And often your poor old mum's atopic as well, and she's vacuuming madly every day and copying all her allergic symptoms.
Exactly. And there's quite a few RCTs now to show that allergen reduction or allergen of
particularly with dust
mites are not necessarily effective treatments. And two, it really is the wrong focus. It's focusing on the allergen as the bad guy, when that's not what's going on. I don't respond to the dust mite that some of my patients do, even though we're both exposed to it. And what's going on is the abnormal immune system, and it's modifying the abnormal immune response, which is what's important, not the allergen.